Good afternoon, everyone, and welcome to the oral abstract session on meeting the challenge, community financing for a sustained response. I'll now like to invite my panelists to join me on the stage as we start the session for this lunch period. Thank you very much for coming. I know it's a lunchtime period, so it's not always very favorable, but we're really happy to have your presence. Please, can you join me? All right, so the following set of presentations are really going to give us some insights in terms of quantifying the cost of community interventions, the implementation of community interventions. As we know, this is often an area that we struggle to quantify. I mean, I think a lot of the health costing analysis is really focused at a facility level. And this is very important and critical because as we talk about increase in community investment and scaling up of services, especially like we have models that we've been hearing about throughout the conference on differentiated service delivery, et cetera. What are the opportunity costs for community engagement? What does the cost actually look like for community interventions? So we're going to hear from our panelists. We're going to just take all the presentations and then allow time at the end for some discussions around from what we've heard from the interventions. So let's start first. I would like to invite Dr. Khan, who's going to give us a presentation on empirical costs of community mobilization activities to support the scale-up of universal test and treat in Swaziland.
Thank you. Good afternoon. First of all, I'd really like to thank the organizers for giving us an opportunity to share our results on Maxheart. So Maxheart was a study that was done in Swaziland from September 2014 to August 2017. It was a consortium of a lot of different partners, and what we were trying to actually study was to figure out whether providing art to everybody in the facilities that we were working in, was it affordable, scalable, and actually feasible as well. And one of the aspects we were also looking at was a community aspect, since we were going to be going into those communities, helping them understand what early access to art is or universal treat means, so that they can actually then access those services at the facility level. So this is just basically just an overview of different consortium partners. It's made up of academics, community workers. So it's a very dynamic set of people. So that was actually quite interesting. So in this talk, I'll be mostly talking about the stuff that our two community partners did. One was SNAPA, which is Swaziland National Network of People Living with HIV/AIDS, and SAFAIDS, Southern Africa AIDS Information Dissemination Service. So we went in, with their help, we were able to actually cost out all the different type of activities they did on the ground. So the activities that we will be mostly focusing on will be children orientation, just which we did with the community partners as well as the traditional leaders, just to let them know that we're coming into their facilities and we'll be providing these services. Community dialogues, which happened during the transition period when all those facilities started providing early access to art, so that we could go into these communities, and we did different type of dialogues with the community, so that to empower them, to let them know exactly what's happening in their facilities and they can access those services. In addition, we developed a lot of IEC materials that were placed in facilities as well as given out in the communities, and also monitoring and evaluation activities. So all of these activities, as you see, these are some things that would need to be done even under policy. So even when the country starts scaling up universal test and treat, they would need to take these to do these activities as well. So we really wanted to cost them out. Now, community costing, one of the biggest questions is that all the funders keep asking, which speaker kind of mentioned, was what is the value, right? Like, so to be able to determine the value, you need to have two different components. You need to know what it cost and what it would be the value of that investment as well. So in this talk, we're mostly really just talking about the costing component right now. And the value component, we're actually trying to analyze that data as well so that we could actually give something very concrete to our funders, so to basically make the case of that we really need to have very robust community activities built in, not just providing drugs, but as well as going out in the communities as well. So when we spent approximately $70,000 over a period of 3 years. 71% of the cost was actually really the community dialogues. They're quite expensive. And the rest of the components were M&E, IEC material, and also the orientation workshops. So when we looked at the community events, we actually, throughout the study, we actually did try to do different type of community events. And one was, so the two that I would most be hitting on would be the general dialogues, which is basically you go into the community, you just tell everybody, you bring music, there's dancing, there's food, everybody comes out, they can test, and also their talks and their speeches. So we found that those activities actually tend to be quite expensive. I mean, we're thinking about $650 per event. Then another events that we did was more targeted. Here we were actually trying to target special groups. I've just listed out only 3 here, but there were actually more different other groups as well. So the idea was to basically, instead of trying to go general, where there would be just people who are just coming just for the fun of it, to actually hit people who might be actually impacted by HIV and AIDS and actually really need that information. So some of the groups that we targeted were women of reproductive age, men 30 years or older, sex workers, uniformed services as well. Now, to put all this into context, right? 60,000 seems like a big number. So you want to know, okay, so we actually went back and we were like, okay, as part of the study, we actually did the costing of how much does it actually cost us to treat one ART patient per year. So when we do that, what we find is we spend about $20 on doing the labs, which is doing the viral load test, CD4 test, full blood counts, etc. The TB cost of treating somebody who has TB, personnel costs, which make up actually almost half of the cost. These are the costs of hiring nurses who actually take care of the patients, and then the ARV drug cost. So these are the cost of the art, providing art. So the community, we actually estimated probably costs about $8 per year per person. And the way this is a very conservative number actually. So the way we actually figured that out was we spent about $60,000 in 3 years. So that means it's an investment of about $20,000 a year. And in our study, we actually enrolled about 3,000 clients, 3,400 clients. So we said, okay, how much would it cost those if we wanted to just, all of our impact was only those 3,400, which we know that's not true. I mean, there's a lot of spillover effect. We might have been reaching a lot of different other people as well. So even using that conservative number, we're actually seeing that all we're spending is about $8, which is nothing. I mean, it's 4% of the actual cost of providing art care to a patient. So in conclusion, basically, I mean, the cost of providing community service per patient per year for an art client is marginal. It's really not that much. And the largest category of our costs really just make up of the community mobilization. I think we could reach efficiency there as well, as I've showed that using general versus targeted. So I mean, there's definitely room for efficiencies there. We could design programs that are a little bit more efficient, where we're actually really targeting people who actually need to be able to access services. And then finally, there's still a huge gap left, and I'm hoping some of our speakers could be able to speak to that, which is to actually figure out exactly what is the effectiveness of community will be. And I understand it's a very hard question, because how do you determine effectiveness? Do we try to say that how many people are actually accessing services, how many people are actually testing, or how many people are actually getting on art? And especially the fact is it's the effectiveness just not limited to people who are accessing services also. It's also about education, because it's like prevention as well, right? Like, if people are motivated, they understand what's going on, they might be more likely to use condoms or be able to access PrEP, because that's another services that we are looking at. Thank you.
Thank you very much. My apologies. In my excitement to get started with all the information, I forgot to introduce myself. My name is Wame Musime. I am with the International Treatment Preparedness Coalition, ITPC. And with that, I would like to invite our next speaker. Bear with me, I'm trying to pronounce it properly. Mr. Rungtanatada is going to give us a presentation on increased domestic financing of key population-led health services, lessons from Thailand's transition planning and purpose. So you're welcome.
Good afternoon, everyone. My name is Kantinan Rungtanatada. I'm manager of TB program in the National Health Security Office of Thailand. I would like to take opportunity to give information briefly the increased domestic financings, a key population-led health service, a lesson from Thailand transition planning and response. As Thailand is preparing for transition from the international funding, international financing funding from Thailand. Sorry. I'm nervous. There is an agenda to increase domestic HIV response, especially to ensure continued involvement of civil society organizations as key population-led health service are crucial contribution to ending HIV epidemic in country. Through consultation with Thai Ministry of Public Health, PEPFAR, USAID, and Global Fund, the National Health Security of Thailand has approximately $6 million per month. Oh, sorry, $6 million per year, or 200 million Thai baht per year. The initiative was designed to have the expertise, service capacity of key population-led health service organizations, many of whom have been traditionally financed by PEPFAR or Global Fund. The National Health Security of Thailand developed reimbursement scheme based on cost of estimates of risk, referral to testing, and retention activity for HIV testing, negative and positive client, which vary for each group, each KP group. These amounts were made available. Organization, civil society organization, and hospital provide services key population through contact with an HSO. The reimbursement scheme consists of 64 million Thai baht for MSM and TG, and 16 million baht for female sex worker and 16 million baht for PWID. During the time period of fiscal year 2015 to 2016, the National Health Security Office significantly increased the support to organizations, including civil society organizations and hospitals, provide outreach, HIV testing and service key population, includes MSM, premium sex worker, and PWID. However, despite it increased the government budgetary support for key population-led health service, certain gaps remain. Only an estimate 40% of were fund provided to CSO and remaining 60% to provide hospital. Because of the first time of Thailand, the results in delay in contact provide and providing reimbursement to many CSO and conclusion, the National Health Security Office identify this above issue, now collaborating with Ministry of Public Health and PEPFAR, USAID, and Global Fund. And stakeholder to diversify funding and funding option for CSO and strengthen and streamline funding management. Establish certification entities and system to ensure organizational and service capacity for CSO. And the last, ensure that unit costs reflect operational costs of CSO to ensure the sustainability of CSO involvement in HIV service provision key population. Thank you.
Thank you very much. I would now like to invite Sophie Demweek to make a presentation on last to be funded, first to be cut, an analysis of the current funding trends to local community organizations in the Positive Action Network.
Hello everyone. I'd like to thank the conference for inviting me to speak. It's my first AIDS conference, so it's a real honour to be here. And I'm representing the Positive Action for Children Fund and the Positive Action for Women and Girls Fund, which are ViV Healthcare funded support programmes to communities affected by HIV worldwide. Now I'd like to thank my co-authors and also the people who took part in our research. So, in response to anecdotal evidence that funding was flatlining for the types of community groups that we serve in Positive Action was keen to find out directly from our partners what the situation was like in terms of funding on the ground. So we launched what will now be an annual survey looking at funding trends, work with key populations, service provision, and also groups' engagement with us. But I'll be focusing purely on the funding results today. So we had 450 full responses to our survey, which comprised an 8% response rate versus who received the survey. And in country-specific analysis, we excluded countries with less than 13 respondents. And seeing as we were also looking at funding trends just over the past 2 years, we also excluded groups started up in that time. So the two questions I'll be focusing on today are, over the past 2 years, how has your organisation's total amount of funding changed overall? And also, over the past 2 years, how has your organisation's total amount of funding changed for HIV-specific projects? So respondents ranked their answers on a scale from 1 to 5, where 1 showed decreased significantly, 3 represented stayed roughly the same, and 5 represented increased significantly. And you can see the corresponding bars on the chart there. So results did vary by country. We had a mean average score overall of 2.73, so actually just below that middle line, so in the decreased section. But as you can see, there was discrepancies per country. So South Africa, for instance, had a mean average of 2.29, while Zambia had a mean average of 3.16. But as you can see, it's all around that middle line, which is what's important. Moving on to results by organisation income then. So our results seem to show a positive correlation between organisation annual income and the change in HIV-specific funding over the past 2 years. So the HIV-specific funding is the yellow bars that you can see there. So for example, organisations earning less than $50,000 per year saw a decrease in HIV-specific funding over the past 2 years, whereas organisations earning between $50,000 and $200,000 per year saw an increase in funding for HIV-specific projects. Our results seem to show an even stronger correlation between income and overall funding trends over the past 2 years, so those shown by the pink bars on screen, with organisations earning less than $10,000 per year seeing a decrease in funding, whereas organisations earning over $10,000 a year showing an increase in funding, so it's quite a stark contrast there. So key findings then. The first key finding is that funding for these types of community groups that we serve is flatlining, according to our results. And this is despite the high-level meeting in 2016 proposing increased funding to communities to optimise investments in the health system. And secondly, our results seem to show less funding for lower income organisations, both for overall and HIV-specific projects, than for higher income organisations, which is obviously worrying, seeing as that most community organisations are of a lower income. So our results point to the urgency in prioritising funding at community level to bring health services to the doorstep of those who need it, often in really rural settings where people may not have had access to the health system otherwise. And it optimises the investments we are making already in the health system. So this is a call to action for policymakers and funders to really prioritise funding to those groups. So further research will be required to assess the statistical significance of these trends and also delve a little deeper into the issues behind them. But thank you very much. I think we'll do questions at the end. So thank you.
Thank you very much. I would now like to invite our next speaker, Mr. Jamar, who's going to give us a presentation on post-Global Fund HIV financing, a promising transitioning model, and implementation of Plan from Shift program based in Thailand. Thank you.
Good afternoon. Thank you very much. First of all, the most important thing about the SHIFT project is we need to keep F in the term SHIFT, otherwise it would go a little strange. And of course, for the SHIFT program, it stands for the Sustainable HIV Financing in Transition project, which is the regional project supported by the Global Fund, implemented in 4 countries: in Thailand, Indonesia, Malaysia, and also the Philippines. So that's the project. But the operational office is based in Bangkok. Let me get straight to the project itself. The first one is what is needed for the transition. First of all, you need to have a strong political commitment, because in the program we got even the Thai Deputy Prime Minister to actually speak about this transition period by us establishing the program called Is Almost Zero. That would sound more appealing, because it means that just a little bit more than we can AIDS in the country. So we get someone big to speak about that, so that it means that we already have the political commitment that we can follow up. The second thing that we need to have is to have the strong civil society sector. So basically, they could be working in collaboratively, or they have a strong in terms of management and also strong voices to work together in the society. And also, we need to have the knowledge of the public policy system and also governance, because you cannot do a good advocacy work without knowing how the system works or how the policy works in your country. And also, this method has an assumption that there's no previous negative relationship between the government and also the civil society, because if there is, then you have to go and solve that first before going to use this method. The method that I'm talking about is here. It's called the collaborative governance in this model. It's basically a method of the participatory approach, working together more than two parties. It could be the tripartite, like the government sector, and also the beneficiaries, and also the civil society that working together collaboratively. I cannot go into the details, but I have more step-by-step explanation. If you can email me, and I can give you the that easy step to follow. But also this also include the participatory budgeting. It means that when we come up with the process, the civil society join together with the government to decide to make the decision where the money should go, where to allocate it effectively. And also the other thing, the other most important component is share responsibilities, which means that NGO or our civil society sector have to take up some responsibilities that can be accounted for. So the government might have to do something, and we need to do something. And as a civil society, we have to commit to that work. We cannot say that, oh, we are busy, we cannot attend to the meeting anymore. We have to stick together with them to show consistency, and this is very important under this project. So what I'm talking about is to have the four component is first we need to have the CSO funding mechanism. In some countries, there's no such a thing as outsourcing or working collaboratively with the civil society. So you have to create that first. And the second thing is we're focusing on the increased physical space and then allocative efficiency. So basically, fund the things that should be prioritized. And the last one is we need to have the transitioning plan. And also, I didn't realize that one of my top policy advocacy or target audience is actually the second speaker in this room for the National Health Security Office here. So now he knows all of my secrets. But now you know that we have the same set of information, because he just discussed about the grant for 200 million Thai baht, which is approximately 5.7 million US$ for the key population. So our information is the same, and so we have so basically our studies are good, both of us, and also we have the another fund from the Ministry of Public Health that we work together as well. So how do we strengthen the civil society? Basically, we have to form up some kind of coalition. In Thailand, we call CRM, Civil Society Organization Resource Mobilization, to show that we are consisting of more than 34 organizations right now, to show them that there's a strong voice from the community to work with the government, and we can be professional. And but also we have to minimize the risk, not to only work with the government, but also to aim at the private sector or individual donors as well. In case that because that sometimes the government budget can be delayed, like a quarter delay of the financial transaction. So we need something to fill the gaps as well. So this could be, a number of ways. So what needs to be done in the civil society sector is we need to, first of all, we need to have a strategic information that can be feed into the government system to justify that why our issue is really important to be implemented, or why in terms of the allocative efficiency. That's the first one. Second one is capacity building. Many NGOs do not know how to manage the projects effectively. They don't even know how that you need to get the receipts when they buy things. So you need to really get that done. And the third one is strengthen the formal and informal relationship. This is very important, because I can quote from the local state official. One of them said that, I wouldn't trust my money with you if I don't know you personally. This is the very local context, especially in the Southeast Asia. I'm not sure about the rest of the world, but that's the way it is. Because if they don't know us, although that we are really good in portfolio, but they're not going to trust us with their money. And also policy advocacy, you know that. And also the last one is the sharing among countries. That's also SHIFT is providing, which is good because we can learn from other countries and to see at least we can know that, oh, they have more difficult situations, so we're still lucky. So that's win of the day, or we worse, so we should improve ourselves better. Also, we have to be clear together. First, we have to get a shared vision that we need to have the same goal. That's the way to go. So last one is about what could be the key success factors for domestic HIV financing. The first one is that we have to strengthen both I already mentioned this, but also plus shared vision. And the second thing is we need to consider the CSO as the profession, not just only volunteerism. We can still be volunteers, but we have to be very professional. And we need to get ourselves legitimated. In Thailand, for example, we get most organizations registered so that at least and my National Health Security Office, my government counterpart, know who to sue when we run away with the money. So basically, and also we have to be accountable. That means responsibility and also transparency together. And also we have to manage things effectively. And also we have to have the reliable strategic information, which means that we should be a good source of information. So if you ask me, like, what is the percentage of MSM using drugs right now, I should be answer spontaneously, like 25% of the survey population. And communications and consistency, you cannot just only send a letter asking for the meeting, but it should be like on the phone, online, WhatsApp. That should be done as well. Strong collective voice, already mentioned that. And the last one is really important, is we have to respect government staff as equal humans. Because we could just say that you do your job, it's your job, so you have to do it. No, they are just human beings as well. So basically, if you do so, we hope that they would do the same back to us. So that's the lessons learned from Thailand. Thank you very much.
Thank you very much. Thank you very much. That was really great. I really wish we had a lot more time to really delve into a lot more details. Can I invite the next speaker? Mr. Borst, who's going to give us a presentation on a sustained approach to providing HIV services information at community level, a longitudinal exploration of female community health entrepreneurs' performances. Thank you.
Thank you. Okay, good afternoon, everyone, and thank you so much for being here, and thank you for the opportunity to discuss these very first findings here at the AIDS 2018 conference. So my name is Robert. And my intention is to, within the next 5 minutes, convince you of the fact that community health entrepreneurship might be, or might actually be, a very sustainable infrastructure to provide HIV services and information at the very rural community level. So just very briefly, where did we start from? We started from the whole idea that community health workers, both within literature and practice, have proven to be very effective in getting reproductive health care in rural areas. However, performance of such community health workers is often very challenging, as you probably know, mostly relating to retention, but also to the lack of income, because they're usually volunteer workers. And besides that, it's very hard to quantify or to actually measure. And what is the impact of such community health workers? So what did we do then? We focused on community health entrepreneurship, like I said in the beginning. And I won't dive into the very specifics of community health entrepreneurship simply because of lack of time. But Mr. Timo Beentjes, who is here so also in the room, from the organization that actually implemented community health entrepreneurship in several countries across the world, I'm sure he was more than eager to share everything about the model with you today. So what was our aim as researchers? So our aim was to obtain a very rich understanding of community health entrepreneurs' performances in order to contribute to the construction of a sustainable primary sexual and reproductive health care model. So how can we provide at rural communities sexual and reproductive health care that sustains over time? So this is what a training of community health entrepreneurs in Uganda, in this case, looks like. And this is a picture taken by someone from Healthy Entrepreneurs, actually from the organization that implements this model in several countries across the world. So what did we then do? What were our methods? This exploration of the performances and the impact of community health entrepreneurship is part of a mixed methods research project, meaning that we do a track of ethnographic research, observations and interviews, but also a track of quantitative research. And today I will tell you about the findings of the quantitative parts of the tablet-based surveys. So what is to us performance of community health workers? We operationalize that along the lines of 4 indicators, or 4 proxies you could say, which is the availability of essential medicines, availability of key products, the income, weekly income in US dollars I should say, and the self-esteem by means of Rosenberg's self-esteem score. So what do we do then? We compared a group that had been trained as community health entrepreneur with a group that will or would be trained in the future but so far had not been, meaning we compared community health workers working at the local level with community health entrepreneurs on these 4 indicators as mentioned on the slides. And we did that during a period of 6 months, so actually a very brief period, so these are also very premier findings to that extent. So what are the results? 4 things. The entrepreneurs proved to have a higher availability of essential medicines, and that includes free condoms. And the odds ratio is quite high, actually. A moderately higher availability of key equipment. That includes basic equipment to provide services at the rural level. And later on in the presentation, I will show you a link through which you can find the very specifics of these analyses. Thirdly, a slightly higher Rosenberg's self-esteem score, slightly higher, but that is within 6 months. So again, what does that mean for the future? And might it be even a bigger difference in the near future? And I think this is the 4th and most important aspect, actually. The healthy entrepreneurs proved to have a higher average weekly income, and quite substantially higher, actually. So what does that then mean? What do the results mean? 3 things. First being, the community health entrepreneurs, based on our findings, I could say, can be key actors in providing more sustainable and more sustainable sexual and reproductive health care at rural levels. Second, the higher self-esteem, as reflected in the Rosenberg self-esteem score, and it's known in the literature that this reduces risk-taking behavior among those which we measured, meaning we measured female healthy entrepreneurs, and their self-esteem was higher. So it might be that their risk-taking behavior is much lower. And the last one, community health entrepreneurship allowed for economic empowerment of the women that became healthy entrepreneurs. So what are the critical side notes? This was after 6 months. What does it mean for 12 months, 24 months, or even longer? Will it sustain? We think it does. And the first findings that are not yet represented in this presentation show that it does. So in AIDS 2020, I will probably show you, hopefully, that it does sustain. And to what extent do these 4 proxies reflect performances? And that also relates to the final point on this slide. So we're doing an ethnographic track of research as well. And that one shows, or actually reiterates, the findings in the quantitative part. So I think it does reflect the performances, the acts and actions of the community health entrepreneurs to quite an extent. And hopefully, again, at AIDS 2020 or in Liverpool later this year, I can show the mixed methods results, so combining both quantitative and qualitative. Thank you so much for listening. Should there be any questions, please look at the poster, scan the QR code, which is on the poster as well. You can just use your regular app or a third-party app. Ask Mr. Timo Beentjes from Healthy Entrepreneurs about the model, or visit his poster, which is presented at the exhibition. Thank you.
Thank you. I'll now like to invite our last presentation from Mr. Bagas on building a constituency of advocates for sustainability, identifying the capacity needs of HIV CSO, key populations to advocate for HIV financing and sustainability in Indonesia, Malaysia, Philippines, and Thailand.
That was a long title. Thank you. And thank you for the opportunity to make this presentation. I'm from APCASO, a regional network of civil society organizations on health and human rights. And the presentation that I'll do today is about the needs assessment that we've conducted for SHIFT, which was already introduced by earlier, the Sustainable for HIV Financing in Transition program. Now, Now, in this conference, we do know that donor funding is flatlining. We also need a scale-up in investment for our HIV strategies. And not only do we need a scale-up, we also need to front-load the investment for our HIV strategies. At the same time, we also have evidence that domestic spending for health has actually been increasing, which provides us with the opportunity to look for additional resources on the ground or domestically. Now, to enable that to happen, we need advocacy, of course, and to know how we can advocate, then we need more data and information. What are the needs of HIV civil society organizations, of HIV advocates, to do advocacy specific to HIV financing and sustainability? And that's the reason why we did this needs assessment. The first thing that we did was to develop a tool that looked into capacity in 5 areas. The first one to guide, the first set will be to guide CSOs to self-rate their capacity in programmatic, organizational, and individual areas. We also looked into their connection or ties with HIV financing stakeholders or decision makers. And lastly, we delved into the strategies that they have in their HIV financing advocacy, whether there's actually existing space on the ground to be able to implement those advocacy. After the development of the tool, we conducted 4 structured discussion groups in these 4 countries from June 2017 to December 2017. So we reached out to existing HIV coalitions in these 4 countries, most of which are actually have been doing HIV advocacy already. We were able to reach 28 CSOs and key population organizations or networks in the 4 countries, made sure also that there was ample representation coming from key population groups, coming from PLHIV organizations. And the results from the needs assessment were developed into a set of internal reports that guided the SHIFT program. So what were our findings? The first one is something that we actually expected, that while advocacy is strong among HIV CSOs or key population networks, the understanding on specific or technical HIV financing subjects were weak to moderate. So these would involve issues around transition policies of the Global Fund or other donors, universal health coverage, and budget cycles, how government agencies develop their own budgets. The second is the fact that despite the recognition that advocacy is part of the mandates of the organization, it's seen as an add-on to service delivery and not really prioritized. It's hardly visible in the strategic plans of many organizations. There were also limited engagements with budget stakeholders and decision makers. So our engagements with government officials have so far been defined by what's being prescribed by the CCM, for example, or those who are involved in the CCM. But we don't know the roles of the ministers for finance, the treasury, the roles that political parties play in the whole financing ecosystem. In these 4 countries, decentralization also presented opportunities to do advocacy, but it's hardly optimized by many organizations. So the focus is, for many, is on at the national level. Within coalitions, the capacity for key population investment-related issues also vary, which means that in hostile environments, we need to capacitate the coalitions more about the investment needs for people who use drugs or for sex workers. The results from the needs assessment were very useful for us in designing our own advocacy trainings, which we conducted in the 4 countries. For example, we tailored the design based on the results of the needs assessment. We also had to conduct 2 trainings in Malaysia in response to the result of the needs assessment. We also developed a set of technical assistance plans for Indonesia, Malaysia, the Philippines, and Thailand, which I believe the current program partners are expected to implement. And it also helped us develop our own CSO advocacy framework on HIV financing and sustainability, which we hope could be a lasting legacy for the SHIFT programs, and the framework would guide CSOs in trying to define their own advocacy goals, strategies, and activities in this space. Thank you very much.
Thank you. Thank you very much for our panelists. There were some very interesting and maybe discouraging as well, results that we've seen around the funding that were, so in terms of both quantifying the costs of community interventions, as we're looking at scaling up the HIV/AIDS response, as we're looking at issues of coverage in order to ensure impact. There's some really careful considerations that we need to make about what does it actually really take to finance civil society to be actively part of the process of implementation at a national level. We heard a lot from our panelists around the need for facilitating demand creation and scaling up some of the flatlining, budget advocacy, to scale up some of the flatlining that's happening within countries in terms of donor funding and some of the opportunities that we need around community system strengthening. As we shift to domestic funding, which services or programs such as Keep Population Program and the impact that it would potentially have on us being able to deliver at community level. So given that, I would now like to invite some questions and answer. We have about 10 minutes or 15 minutes left. Are there any questions that we would like to ask our panelists?
Yes, I'm Anna Filipovska. I'm regional coordinator of the Regional Coordinating Mechanism representing 9 countries from Southeast Europe region. We also, majority of our countries exit out Global Fund and majority of international funding. And we had a lot of challenges regarding reaching sustainability of HIV and tuberculosis response in our region, even though we have some of the countries that did make great advocacy towards sustainability of HIV response, we saw a lot of gaps in between. And thank you very much mentioning entrepreneurship, like that is very important and very forgotten way. And also talking about knowledge and information on financial sustainability of HIV response. But I would like, I think in AIDS international community, we rarely talk about additional innovative local initiative funding. And this includes, because sustainable HIV response is not just covering treatment, care, prevention, but it's also economic empowerment of key population. Because we want key population to go out of marginalization, stigma. And I think social entrepreneurship, community entrepreneurship, and all these local innovative initiatives is the part of solution. Thank you.
Thank you. Number 4.
Thank you very much for all these great presentations. My name is Natalia from the Thai Red Cross AIDS Research Center in Bangkok, Thailand. I would like, coming from Thailand, I think that it is very now a very urgent time for us to implement the transition. What I've heard from Jonas and from Rapipan is that it is very good that we have all these formative assessments. Combining aspects from the CSO themselves as well as those stakeholders in the countries that you're working in. What I have not really seen from the presentations is what is actually the tangible next steps or next action plans that you plan to advocate for in these countries. Because as you can also hear from Dr. Kantinan, in Thailand we will start the transition, the actual transition very soon in the next few months. How do you think that all this formative information will actually feed into the action, or is it time now to really take action rather than to do more formative assessments, because it would take years and years, and Global Fund will spend money on doing formative assessments in which actually we know the answer already. It's just a time to take action, I think.
Thank you. One more from number 3.
Okay.
No, 2.
Thank you very much to all the speakers for all the information you're giving to us. My name is Dr. Iwekuchukwumwaya. I work for Physicians for Social Justice in Nigeria. My question is directed to Sophie. I want to thank Viva Healthcare for all the support you give to civil society organizations all over the world, especially in sub-Saharan Africa. But in the slide you showed, For the smaller community-based organizations, it actually shows that the funding is going down, but for the bigger organizations, the funding is going up. My question is that given these preliminary results of funding, decreasing funding for the smaller CBOs, how can you reach out? I'm talking about Viva Healthcare and the Positive Action Network, because your model of funding has been proven to be one of the best and most innovative for smaller organizations. But a lot of these smaller organizations, I know some of them will not even bother applying for some other funding because of the stringent and very complex funding mechanisms that have been put in place by some other donors. So I don't know whether are there ways that you reach out to fellow donors to talk to them and maybe probably convince them or do advocacy for them to follow your model, which is, I actually say, is one of the best models I've seen in the world, so that these smaller organizations that are doing very incredible work at the community level can have access to funding.
Thank you. Can I take some answers from the panel?
Yeah, sure. Thank you very much for your question and for recognising our model of focusing on community groups, because I think you're right, it's so important to fund those tiny groups that are often in really rural grassroots communities. So, no, we think it's really important too, and that's part of what this research was about, was to advocate for other funders doing the same. And we do have partnerships with other funders, but I can talk to you more afterwards about that. But agree with you that it's worrying to see that smaller organisations are having less funding. And you're right, other international donors have really stringent, things that hoops that groups have to jump through, if you like. But we really kind of pride ourselves on providing funding to those exact type of groups that you're talking about. So I'll pick up with you after about how we can do that. Thank you.
Thank you.
For my part, I let the formative assessment to Jonas, but I'll answer that why Thailand should move it now. So actually, in reality, Dr. Nia is very right that we should actually jump to have a quick leap to actually take the country to own the global fund right away. So what has been done so far is but it's not the case, of course. Like Dr. Nia mentioned, first of all, we have to develop the plan packages, because now some of the funding in our country, the only indicators, not the NGSO, but the other one is one indicator is to have 500 projects in 1 year for that particular budget. No other indicators. So that means that the budget is not being spent effectively. So we try to improve that so that the government can actually ask for more increased fiscal space from the cabinet as well. But for the NGSO, there is another problem, is the capacity of the local CSO at the subnational level that we need to address about. But big organizations like Thai Red Cross, Rainbow Sky, and many other big NGOs that don't have the management problems, but there are small ones that we need to work on. And also, that's the second thing. So this is going to be the balance between the incrementalism, not to go to the academic term, incrementalism and rationalism. So basically, we have to take the small wins in order to make a big change. It may not be as drastic as we desired, but at least we move toward the achievement. So it won't be 10 years, but of course it's slowly. So maybe there could be something that we can work collaboratively a lot more to make the process faster.
Thank you.
I actually quite agree that the time to act is now, and that countries should be developing their own sustainability plans and start implementing those even prior to transition. But I think formative assessment and evidence building should be part of that, because we really lack evidence related to investment. One realization that we have, for example, is that the way that we develop our investment plans are quite different from the way governments develop their budgets. Different cost items, different budget items. So how do you reconcile both? It gets lost in translation. So we need this kind of evidence so that we can plan appropriately. And I do agree about innovative local initiatives on financing, and I'm a big fan of subnational engagement, especially in countries with decentralized and devolved system. There's one technical assistance activity that we supported, that Shift supported for Indonesia, where community groups in cities in Bandung and Semarang were capacitated to look into local budgets and identify what's the funding stream for HIV? Is this the correct use of public funds? Or where can they find efficiency in their city budget to advocate for reallocation for HIV programs? And I think we get, in terms of, I suppose, the amount that we get from these engagements, that would be small compared to the bigger picture, but it represents a space that we have. It's not the government isn't a monolithic block. There are spaces for engagement, even in countries with criminalization laws.
Thank you. Of course.
Just a very brief remark on your observation on social entrepreneurship, that it's often being overlooked, and I couldn't agree with you more. And I was quite surprised to hear this morning, I heard Professor Pio talking about community health workers, and then I thought, well, how about the performance of community health workers, and how, I mean, they're often lay workers, what they call them. I don't know why they call them lay workers, but they're volunteers, and volunteers, I think it's a great thing, but it's often not sustainable, because, I mean, you need to earn an income, right? And you know, it makes sense. And then social entrepreneurship could be a very good alternative, and it's often overlooked, and I don't know why. So please advocate for it more. Yeah, thank you.
Great, thank you. We also had, okay, I guess they're set. Okay, number 3 and number 4.
Yeah, Cipriano Martin is from Australia. I'm wondering if the panel could reflect and give me some views. Transitioning often means less money from the global north to the global south. During the transitioning period, the likelihood is that there will be underspend rather than overspend. And given that there is likely to be a significant underspend, how are the organisations on the ground going to handle politically organising to actually bring that back up? Because if we're I think it's important to do what you're doing in terms of the action plans and cycles and understanding all that information. But I'm just wondering, once the underspend occurs, it's the political activism and action that then is required to make those, make those governments accountable. Before Global Fund provided the money, there was a massive underspend. So what's going to be different this time? So I'm just being challenging.
Okay, thank you. Number 4.
Hi, Bernard Nanakon from the Thai Red Cross Research Center. Going to the questions regarding on the mechanism for the funding from the when the global funds are cut down from the country for the Thailand as well. But when I look at in the presentations, you focus on the training advocacy. It might not, from my perspective, it might not enough for advocate for the country, or for even for the CVO to receive the money for the government. But the point that I would like to make is whether or not you look at in the law and barriers that might be to prevent the community-based organization that is not in the past of the government to provide a healthcare system in the past. But I think it might be, rather than just focus on training advocacy, it should go beyond that to think about how can we break through the structure barrier that might be need more than training for the community, but need to be the leadership to talk about and open the forums to how we can move forward in that way and try to, even you cannot to flow the money 100%, it might be to select the potential organization to pilot on the potential mechanism and then to look at how to forward. But I think it's good to train in the community, but need to go beyond that. Thank you.
Thank you. Last comment, if you can make it brief, sir. We have 1 minute just to get feedback from the panel.
Okay, thank you. My question is, I think, to Robert. Just wanted to confirm the community health entrepreneurship. Is it almost the same as the volunteers, what we call volunteers, if it's not the same? What are the exact issues and the differences that make someone maybe, because significantly we work with volunteers or caregivers or this group of people that we think are serving the community. But what makes these people then community health entrepreneurs from the volunteers? Because this is, I think, the learning curve that I'm interested in, because I think it will be an upgrade that I would want also to take home. The second one is on the issue of domestic HIV funding and its implications in terms of issues that have to do with advocacy. I think more often than not, we have noted that NGOs, particularly civil society organizations, they go where the government is failing, and they also reach out to those hidden populations. And then you'd find that when you then engage, you are looking at domestic financing, sometimes you tend to be swayed to follow the general picture, and then we lose out to those people. How do we then make domestic financing reach out in the same manner that we are reaching out to key populations particularly, and also to those hidden segments of the community that we are reaching out through global financing.
Thank you. Thank you very much. Can we get 2 responses to the questions, so we've run out of time?
Okay. In terms of the laws, in Thailand especially, we have already conducted the law that there are the barriers to the HIV financing, and we found 2 different things. The first one is we actually found that the associations and foundations, which are the non-profit organizations, are not entitled to receive the funding. That's the law that we need to work on. We have already identified that, but that's not the only case, because we also found that there are some laws that could bypass that law, but it's about the attitudes of the local implementers that they don't trust or they don't want to give it funding because they are not sure whether the money is gone. So we have to work on both ways. So yeah, the study is already completed, we already published it, but it will be disseminated soon after this. And the first one, I think that's for my point. Jonas.
On global fund underspending, I think that says more about how we're structuring the transition agenda more than the capacity of countries to absorb these resources. So we really need to examine the transition policies of the Global Fund and see whether they're, in a sense, viable. On the issue of more than trainings, definitely. So our role in the SHIFT program is to deliver trainings, but each country has their own package of interventions and activities supported by SHIFT. My last point is actually something I missed to raise earlier about innovations on the ground. The presentation earlier from NHSO is an example where a universal health coverage scheme actually procures services coming from community organizations. And I haven't seen any model similar to that in any other country. So I think it's something that we can learn about and see UHC as a vehicle or a platform where we can sustain our own HIV responses.
Thank you, Boris. If you want to just give one last.
10 seconds only. No, thank you for the very relevant question. And what is the difference between a volunteer and an entrepreneur? Well, I think everyone can be an entrepreneur, but there's just not always the, let's say, infrastructure or the guidance to become an entrepreneur. I think what this model clearly does is offer guidance in how to become an entrepreneur, and thus move from being a volunteer to someone gaining an actual income with the activities that you do.
Thank you. Thank you very much to our panelists and the rich presentations we've heard. There's a lot of food for thought. There's a lot of advocacy we need to do around community health system strengthening as well as budget advocacy. Have a really great rest of the conference, and thank you.